Hello, this is Dr. Kim Jung-dul. Today, I will lecture on first-order bends among dental factors of the causative factors of malocclusion. Tooth movement is possible in three dimensions, which are called first-order bends, second-order bends, and third-order bends. First is the first-order bends. The first-order bends are observing the labiolingual relationship of the teeth on the horizontal plane. In other words, you need to know what to observe when viewing the upper and lower dental arches from the occlusal plane. But the basic thing to see is the ideal arch form. At this time, the first thing to evaluate is whether the maxillary first molar is mesial rotation or parallel, or it is whether there is a positional deviation. The next thing to evaluate transverse dimension. At this time, it is the transpalatal width between the maxillary first molar and the intercanine width between the maxillary and mandibular canines. Next, we evaluate the ideal arch form and symmetry of the maxillary canine. These evaluations are mainly possible through model analysis. To find out if the maxillary first molar is parallel or mesial rotations, first, you can see if the buccal area of the first molar is parallel. Another way is that the line that meets the distobuccal cusp and mesiolingual cusp of the maxillary first molar passes through the canine on the other side. When you draw a line like this, you can see that tooth 26 in the first picture has severe mesial rotation. The parallel rotation of the maxillary first molar means that the distobuccal cusp of the mandible is located in the central fossa of the maxilla. The mesial rotation of the maxillary first molar is located below the oblique ridge. This increases the likelihood of class 2 malocclusion, which can lead to mandibular posterior and maxillary anterior movement as the retrusive control collapses. When the maxillary first molar is mesial rotated, most of them have a V-shaped arch form. Setlin was said in 80 of patients with a V-shaped arch form with mesial rotation of the maxillary first molar. There is an interfere with premolar contact and lateral excursion. If you replace the maxillary first molar with parallel rotation, you will be able to improve class 2 malocclusion and obtain class 1 relationship. So far, the mesial rotations of maxillary first molar have the possibility of class 2 malocclusion, and space gain is possible by changing it to parallel rotations in non-extraction treatment. Next is the positional deviation evaluation of the maxillary first molar. To evaluate this, you must first make an accurate model. After drawing a line that is perpendicular to the maxillary mesial palatal raphe in the model, the left and right sides must be constant by measuring the distance to the contact point of the left and right first molar. In some cases, positional deviations with different left and right distances can be observed, which means that there have midline deviations, or both the upper and lower are deviated by compensation. There is a positional deviation in the mandibular first molar, as shown in the picture, if the treatment is non-extracted treatment. The first molar on the right must move posteriorly. If this is a premolar extraction case, tooth 36 is recommended to move forward, so tooth 35 will be helpful for treatment. Next is the evaluation of the transverse dimension. In particular, it evaluates whether the arch width of the maxilla is wide or narrow. Among the class 2 malocclusions, the wide upper arch has a relatively large number of maxillary protrusion or deep bite. On the other hand, narrow upper arch is often observed in class 3 malocclusion of anterior cross bite, midline deviation due to posterior cross bite, mandibular retrognathic class 2 malocclusion, and open bite. So, what is the basis for evaluating whether the upper arch is narrow or wide? I evaluate it by TPW, transpalatal width. TPW, transpalatal width, measures the shortest distance between the maxillary first molars. Since the maxillary first molar erupts around the age of 6, the TPW between the first molars increases from 32 mm at the age 7 to 35 mm at the age 15. TPW increases from 32 mm at age 7 to 35 mm at age 15. However, it is said that if it is smaller than 31 mm at the age of 7, it will not increase to 35 mm even if it is increased later. If so, the extension of the maxillary arch will be necessary. Narrow TPW is highly likely to be posterior cross-bite, Class 3, Class 2 malocclusion. In such malocclusion, first observe whether the maxillary is narrow and evaluate whether enlargement is necessary. This patient is an 18-year-old adult patient with a narrow TPW of 22.3 mm. The lateral profile is good, but we can observe severe crowding of the upper and lower anterior teeth. This patient has a TPW of 33.4 mm, which is not small, but shows a protrusion lips, and narrow of the upper and lower arch, and the crowding of the lower anterior teeth. Next, we evaluate the intercanine width. Intercanine width measures the distance between the maxillary and mandibular canine. Here, please remember the normal value of 34.1 mm of the intercanine width of the maxilla. If the intercanine width of the maxilla is narrow, the mandible cannot move to forward and becomes a Class 2 relationship, or the relationship is Class 1, but the mandibular anterior teeth are severe crowding. So, not only TPW, but also ICW must be measured. This patient has a large overjet and a Class 2 malocclusion. Intercanine width is 30 mm narrow, but lateral profile is good, and mandibular is a 3 incisors case. This patient's intercanine width is 35.5 mm, which is sufficient. Next, evaluate the arch form. There are tapered, ovoid, and square arch form types. Next, we evaluate the symmetry of the maxillary canine and the contact point of the maxillary. In type A, the canine on both sides of the maxilla and the contact point of the maxillary premolar are symmetrical. Type B is the case that the premolar and molar teeth are moved due to the early loss of the left deciduous molar. Type C is the case that only the premolar is moved due to the early loss of the left deciduous molar. And type D is the case that only molar teeth are moved due to the early loss of the left deciduous molar. In the case of type E, we usually extract tooth 25, but which tooth should be extracted on the right side at this time? Since tooth 16 needs to be moved forward, it is better to extract tooth 15 than tooth 14. Therefore, it is important to observe whether the canine on both sides of the maxilla and the contact point of the maxillary premolar are symmetrical. And if it is asymmetric, it is important to make a treatment plan so that it can be symmetrical. In some patients, anterior cross bites occur due to insufficient space for permanent teeth. In the case of premature loss of deciduous teeth, at this time, if there is no crowding in the mandible, it is recommended to create space in the maxilla and induce the forward movement of the maxilla. These patients have prolonged retention of deciduous teeth. The patient's occlusion is good, but the crowding of the mandibular anterior teeth is severe. due to the prolonged retained deciduous teeth in this area. And we can see the midline deviation and edge-to-edge bite. In summary, what should we evaluate on first-order bends? First, observe the ideal arch form on the occlusal surface. Evaluate whether the first molar is parallel or mesial rotation. Measure TPW and ICW to assess transverse dimensions. And determine the symmetry of the upper canine and the first premolar contact point. Thank you for watching.